Hey y'all, welcome back. As promised, in this video, we are going to get into the use of the DSM. To this point, we've had videos describing why we diagnose, sort of a second video about sort of setting our conceptual lens for gathering information and making decisions about that information. And now we are going to kind of follow that up with a tour around the DSM and guidelines for how to apply our information gathering decision making within the context of the DSM. And we will conclude this video with a brief sort of introduction to the case vignette series of assignments, kind of give you a picture about what to expect from that assignment and what I'm expecting from you. So I want to cover a lot of ground in a short amount of time, so let's get right to it. So this is your Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision. And as you can see from the contents page here that I've put up here, although the general text is very difficult to read with the size of this slide, you can see that there are essentially 3 main sections. There's a sort of a background info and how to use the manual, the classes of disorders with diagnostic criteria and codes are part of section 2. And then section 3 includes information about emerging measures and models. This is all about sort of assisting with gathering information and then also discussing implications for research and also supporting further advancements for the revision of the DSM down the road. We will spend, though, the majority of our time in section 2, given that this is a class that is designed to prepare you primarily as clinicians. So section 2 is organized into chapters or classes of disorders. There are 22 chapters, 20 of which will be our main focus. And these chapters are organized in developmental fashion. So you will find that neurodevelopmental disorders are the first chapter, and neurocognitive disorders, which typically manifest much later in life, are described toward the end of the manual. This organization is broad in that each class is ordered according to when developmentally symptoms and other criteria are likely to manifest. And is also, this developmental organization is also specific to each disorder, and each disorder is ordered according to when the class specific symptoms are likely to manifest. So, for example, when you are examining these trauma and stressor related class of disorders, you will find that reactive attachment disorder comes before acute stress disorder, which comes before a post-traumatic stress disorder. And the reasons for that will be abundantly clear when we get to that class of disorders. Classes of disorders are grouped by unifying themes, like I just mentioned, trauma and stressor related disorders. There's also, as I mentioned, neurodevelopmental, there's mood, there's sexual dysfunctions. The classes or the unifying themes sometimes are complex, but most of the time they're pretty straightforward. And I think you'll find them to be easy to follow and grasp. And then each disorder, as it is described within the DSM, within each class of disorders includes the diagnostic criteria, typically with an alphabetical sort of outline. And then there are also sub-criteria, which will often have a numerical outline. There will be specifiers, which typically get at sort of the severity of symptoms, the duration of symptoms, and other features, perhaps like psychotic features that may accompany the diagnostic criteria for a certain disorder. And then, of course, there is an alphanumeric code, which is used for sort of recording purposes. These alphanumeric codes align with the International Classification of Disorders 11th edition, which is essentially the codification system of all healthcare concerns In fact, I may have misspoken. I think it's the International Classification of Diseases, not disorders. All that to say, the DSM prior to DSM-5 TR had its own sort of numeric codification system. The TR has done away with that codification system to align exclusively with ICD-11. So you will find that there are F codes, R codes, G codes, and Z codes. Primarily what you'll be noticing is that you will be in the F code sort of range of the alphanumeric coding system. So diagnosis, keep in mind, is only one part of the case formulation process. This class is going to teach you how to use the information gathered in a diagnostic interview and other structured assessment instruments to first determine the class of a disorder into which the data best fits, differentiate between disorders by using the diagnostic criteria and other details from the differential diagnosis section in the full manual, specify according to specifiers or for severity, duration, and features, as I just mentioned, and then of course, coding and then recording the diagnosis within sort of client-specific documentation. In the event that there are multiple diagnoses that are relevant for the treatment you'll be providing, the current system is to prioritize based on clinical focus. So if you are working with a person who meets criteria for attention deficit hyperactivity disorder or ADHD, that will likely be first, but you may also, since you're working with a child, be most likely working with a child. You'll also may want to consider adding a Z code for parent-child relationship problem, which is likely to be part of your focus of treatment. So that's a topic for another course altogether. The point that we're trying to make here is that oftentimes you're going to have a primary mental health diagnosis, and then you may have a secondary or tertiary diagnosis as well that will be relevant for clinical focus. So as you can see here, these are some relatively small sort of pictures, but in your DSM, you're going to find that there will be diagnostic criteria. The DSM-5 TR does a nice job of sort of color coding these things to make them a little bit more easy to read. Here we have ADHD, and you'll see that in the pink region, you'll have criteria A, and in criteria A, you will have a number of sub-criteria. So criteria A is there has to be a persistent pattern of inattention and/or hyperactivity, impulsivity that interferes with functioning or development, as characterized by sort of subcriterion 1 and/or subcriterion 2. So the subcriterion 1 is inattention. So there must be 6 or more of these sort of lowercase alphabetical criteria. And then for criterion 2, there must be 6 or more of the following symptoms that persisted for at least 6 months to a degree that is inconsistent with developmental level, and that negatively impacts directly on social and academic occupational activities. So that gets at, again, there must be some type of impairment to what is considered to be developmentally appropriate functioning, and there must be an adequate duration. It is not necessarily disordered if the symptoms resolve within 6 months. Criterion B is that several inattentive or hyperactive impulsive symptoms were present prior to the age of 12. Criterion C is several inattentive or hyperactive impulsive symptoms are present in 2 or more settings. So this is not something that should be diagnosed if it's only happening in one setting, like at school. There's clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And the symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder, and are not better explained by another mental disorder. And then there are a series of different specifiers, such as there's a specific code for a combined presentation, a predominantly inattentive presentation, and predominantly hyperactive impulsive presentation. We need to specify if it is in partial remission. And then there's criteria listed there for what that what would constitute partial remission. And then you need to specify in terms of whether or not the severity is mild, moderate, or severe. So that's sort of a basic example of what to expect in the DSM-5 TR when it comes to a certain disorder and the criteria and the coding procedures for that disorder. Now, as you will notice too, this is in the full manual. There will be further information about diagnostic features that provide sort of that guide your development of your clinical senses. There will be associated features, prevalence, this is how often and how many people are affected by ADHD. There will be sort of a development and course, so sort of information about how ADHD develops and then what to expect during the course of the experience of disorder, sort of risk factors and prognostic factors. So kind of what are some of the dangers that are associated with ADHD, and then what are some of the what is our current understanding of how likely it is that a person's symptoms are likely to resolve, if their suffering will be eased. Well, I want to make sure you really draw your attention to, and I used this, and I still use this section in my larger manual on a regular basis, is the section for each disorder on differential diagnosis. So each disorder will have a oftentimes extensive section, as you can see here, as I've sort of mapped out in green. This section covers 3 different pages in your manual for ADHD, and it will go through a variety of different disorders that are commonly sort of possessing criteria that are similar to the disorder in question. And it will discuss whether or not this disorder can be comorbid with another disorder, the disorder in question, and what sets, for in this case, ADHD apart from reactive attachment disorder or anxiety disorder or PTSD. So this is a super helpful section of your full manual, and you will be required to demonstrate your grasp of differential diagnosis in the case vignette exercises and assignments. This is a very important and key feature of clinical practice that I really want to make sure that you are handling skillfully by the end of this course.